Thanks again, Jay. That was an excellent presentation, outlining some of the most feared complications actually of PCI. So maybe we'll kick it off with Dan Kolansky. Any thoughts, Dan, about wire entrapment and fractures? Has it happened to you? Any thoughts about how to take care of it? I think you're still muted. I'm sorry.
Yeah, it's always a concern. I think those are some great cases. The rotablator cases in particular point out the importance of trying to go slow and lesion preparation and not getting stuck behind the calcium. I think, again, as was pointed out, I think one of the things that happens is that if you're not careful, the burr just shoots across, and we really want to avoid that. I think just being facile with balloon entrapment of the wires to try to go down and rescue and release is the important thing, and it's those are some good techniques that were shown.
Perfect. Mauricio, any thoughts on rotablator entrapment atherectomy? I know it's a rare problem, but when it happens, it can be really serious.
Yes, well, depends on how much time you have and how stable the patient is. In the situations where I went into into this problem, I was lucky enough that I was able to yank the rotablator back and get it back, but that can be a significant problem. And not always you have the space or the space within the corner to wire in the side and put a balloon, which would be ideal. So I think it's a complicated situation, and the best hope is that you can yank it out. One thing that we didn't mention is when wires get trapped inside branches behind the stent, and then you cannot pull anything, and then you can see that the guide catheter just goes in. One alternative is just to soften the calcium and soften the plaque using laser through the main branch, and that in that situation you can disentangle a wire from a stent. So those are my and then the other thing is when the wire unravels, it's very difficult because you just have one filament, and that's happened to me, and it's a bad situation. And in my case, I ended up sending the patient to surgery to be able to remove the wire out, because that filament will not give you enough support to advance a microcatheter. At least that's in my experience. Luckily, I have one or two cases only, but that's a situation. You can actually see if you have wire or not with TEE in the aorta, and you will see the wire. You will see the wire in the aorta just hanging out. So that's why we had to send the patient to surgery to remove it out.
I think that's a very great. I'm sorry. Go ahead.
Oh, just real quick, just to remember, your rotofloppy and your rotostiff wire are 009 that then go to 014 at the end, and the radio opaque, and that's a safety mechanism so the burr won't go off the back. So it's supposed to just go over the 009. So if you ever get yourself stuck, you can bring that wire back to where the radio opaque is at the tip of the burr. Then you can actually put it on Dynaglide, because sometimes it won't spin at the higher frequencies, but you can put it on Dyna, get it to just get going. Because remember, the rotational friction will decrease that longitudinal. That's the whole way that the burr works. You can use those principles to get yourself unstuck. You can pull with the wire and the burr at the same time to get that 014 to catch on the tip of the burr while you're on Dyna and pull that back. And that's gotten me out just a few times.
Does this separate the tip, Rob? If you are on Dyna and you're pulling the wire, do you run the risk of separating the tip of the wire?
It can. It just sort of depends on where you're at in your algorithm of trying to get out of it. Obviously, you don't want to yank too hard. We certainly have seen those wires fracture. All of us have seen that occur a time or two. But it's just one of the things, as long as it's gentle traction, hopefully that's not going to occur.
Yeah, and just a comment about the stent trapment. Jay, I have about 3 stent trapments, and they both came with a CSI, and they both came back with the stent with them. And actually, amazingly enough, that solved the issue, because these stents never expanded, and this time I was able to expand the stent. So what I noticed, and out of 3, that always on a high speed, and never on a low speed entrapment with the stent.
What I find is that it just won't interact with the stent on the low speed, so you have to go to high speed, and then it dulls.
Yeah, so I think the secret to avoiding that is to be even extra slow. That's my 2 cents, and I think you have to basically stand in there and just ablate that area without even moving the burr in and out, and it's better to kind of be on the way back, dragging the burr back as opposed to going in.
So that's exactly the advice I was giving my fellow when it stalled.
Exactly.
So a question
nothing works 100%.
one comment I wanted to make was you have to go out of your comfort zone when you pull the stuck wire, and it's good to have someone who's done that before if you have one, because as a fellow I had to pull, and it was just really very scary, and then the attending had to come help me out. So that's one thing. And then the other point I wanted to make was this wires, when you lose them, probably if the filament is out, probably you can open up the stent and open the stent in the vessel, and then keep it entrapped there if you can get it out through the microcatheter.
I know there's a concern sometimes about jailing wires and the risk of entrapment and fracture. I know, Alison, you've had this conversation several times. So any thoughts? Do people are afraid of jailing wires when bifurcation stenting is done, or are you guys comfortable doing that? So Alison? I'm sorry.
I think for myself, I'm quite comfortable with jailing wires. I think the incidence of actually entrapping a wire when you're just behind a single layer of stent is really quite low. And the other thing that often comes up is which type of wire is actually safer or not safe to jail. And looks like there's, relative similarities with the polymer jacketed wires might actually be a bit better to jail, rather than, I think traditionally there was more of a fear of jailing them. So, but generally speaking, I'm comfortable jailing behind one layer of stent. If I'm doing, say, a DK crush and I'm getting later down in the algorithm and I've now got 2 layers of stent there, I may not jail, but initially I'm quite happy to. I almost always do for simple bifurcation lesions.
Mauricio, you were saying something?
Yes. So why would you CSI inside the stent instead of just do plain old rotablator or laser?
Because they failed.
We've already done that. Failed. This patient's already had contrast laser. He's had rotational atherectomy. He's had brachytherapy, and he keeps coming back. So this is sort of like our last-ditch effort to expand that segment.
And that was intentional to remove the stent, because that's kind of risky. You can run into the other perforations mentioned before.
No, my intent was simply to interact with some of the metal, and I just interacted a little too much.
Just for the record, there are some cases coming up of actually intentional removal of stents, but aorto-ostial stents were sticking back out, which seems to be going okay. But I agree that this is something that probably you don't want to do intentionally unless you absolutely have to. But if you do it looks like you're okay. It's safe most of the time.
One question for the panel and the moderators. Would you be comfortable in leaving, especially decoiled wires protruding into the aorta? Antonio Colombo would say that he would leave them, and most of the time nothing would happen, and the patient would not require surgery. He would not have any thrombosis. But what are your thoughts?
So that's an event that has to be reported to the Joint Commission. I think it has a special code 15 or something like that. So it's like when surgeons leave something behind, like clips or gauze. So you have to deal with that, and you have to tell the patient very carefully that you've done that, and you will follow the patient. That will make everybody very nervous. I mean, I don't know if I have that. In Italy, perhaps it's a little bit different. It makes me a little bit nervous here in the US.
The concern is about the risk of stroke. It's not like, I don't think if you jail that, I don't think it's going to thrombose the coronary artery if you stent it and fixed it. And as long as, so I have surgeons telling me that the stitches they put inside when they do dissection, aortic dissection, they all sticking out, and they are actually much bigger than the filament. So really, there is no kind of data on this to tell us what to do.
And I think oftentimes the risk of trying to get it out is much higher than the risk of leaving it alone. And I think Mauricio's point of letting the patient know and having a good discussion with them about long-term following and potentially management. And I had a case like this once, and we just, in the end opted to just leave the patient on dual antiplatelet therapy, and subsequently it's done fine for about 3 years.